Good afternoon, everybody. Welcome to the second part of our two-part webinar series on managing the effects of treatment for colorectal cancer. My name is Claire Coughlin. I'm the clinical lead for Bowel Cancer UK, and I'm delighted to be chairing the event this afternoon. So if you joined us for the first part, you're very welcome back. If you didn't, then it will be available online and you can go back and watch the first part of this webinar series. Just to recap, that first part that took place on the 2nd of June, we really did quite a lot of setting the scene. So we gave an overview of the effects of treatment for colorectal cancer and how that can really impact our patients. We also had an excellent overview of the health economics. So we talked about the economic impact on individuals, as well as on the health service and on wider society. So some really interesting information in that talk about when you're thinking about potentially having services yourself or just evidencing the need for referring onwards if that's what's necessary. We then shared two service models for late effects services, two very different service models. One that's run by myself. So I'm a nurse consultant at Lewisham and Greenwich, and I run a late effects service there with the support of a multidisciplinary team and multidisciplinary professionals around me. And there was also shared by Sam Bostock, the service that she runs for patients affected by pelvic radiotherapy. So if you haven't watched that part already, then I would encourage you to do so, and it will remain there for your information on our website. So to move on to today's event, I'm really delighted that today we're focusing on the multidisciplinary aspects of a potential service. And the speakers we've got are all multidisciplinary team experts, and they will talk to you about their services and in particular the components of their service. So we are joined, I'll introduce each individual speaker as they come on, but just to give an overview, we're first joined by an excellent consultant gastroenterologist, then by an equally excellent dietitian, all of these healthcare professionals are involved in late effects services. And we're then joined by an excellent speaker on sexual rehabilitation and support after colorectal cancer. And then finally, by an occupational therapist and physiotherapist talking about fatigue and their input into managing effects of treatment. I should just add that we did have a psychologist on the agenda, and if you watch the previous session, you will see that certainly in my talk, I talked a lot about patients needing referral for psychological support services. Unfortunately, at the last minute, they've unavoidably had to withdraw from the session. But I just want to highlight that psychological support is a really important aspect of care for patients after treatment. It's something we can address in the future, and we often do at our national colorectal cancer nurse events and conferences. But I just wanted to highlight here that that's missing from the agenda. But I know you would always consider psychological support for your patients. So just a bit of housekeeping. This event is being recorded and we'll email you the link for the recording as soon as it's available, so you can revisit all the information at your leisure. If you have any questions for our speakers, we absolutely welcome them. There'll be time for a Q&A at the end of today's webinar. So please use the Q&A box at the bottom of the screen and not on the chat, so they can be seen by the speakers. You can introduce yourselves in the chat. We'd love to hear who you are and where you are and who you're watching with. So do please say hi to us in the chat. But if you've got a question, please use the Q&A function. That would be great. So without further ado, I shall introduce our first speaker. So we're going to be joined by Dr. Anna Wilson, who is a consultant gastroenterologist and specialist endoscopist at North West London University Healthcare, NHS Trust. She's a luminal gastroenterologist and specialist gastrointestinal endoscopist. Her special interests include early diagnosis, prevention and treatment of precancerous lesions and cancer through colonoscopy in patients with inflammatory bowel disease and those at increased risk of developing colorectal cancer. And Dr. Wilson also leads a consequences of cancer treatment service at St Mark's. So welcome, Dr. Wilson.
Thank you so much. And thank you for having me over this afternoon. So I thought I would start with a clinical case scenario. And the caveat I would say is that the management of these patients, I believe, is truly multidisciplinary. I don't think there's a single member that can manage the patients on their own. And I think that's often not what we tend to do very well. I used to work at Royal Marsden, which is as close as it got to having multidisciplinary team in one place, where we had nurse specialists and dietitian in the same clinic. And I certainly don't have that at St Mark's. It's sort of very ad hoc. But I'll try and talk to you about how I would approach dealing with these patients. So the case I'd like to present is a patient who I saw a while ago, who was a 35 at the time when I'd met him, who had PT2N2M0, moderately differentiated rectal cancer, aged 31. He has a neoadjuvant chemoradiotherapy and had stoma reversed 2 years prior to me meeting him. And since then had developed quite significant gastrointestinal symptoms. He was opening his bowels 10 times a day and 3 times a night with loose and watery stool. He had significant urge and urgent incontinence and abdominal pain pre-defecation, and had quite a lot of burning sensation, perianal pain, and some rectal bleeding. He scored as having major Lars symptom on a Lars scoring tool. He was unable to work, and he was unable to take his very young children to the park. So what do we mean when we talk about low anterior resection syndrome? So essentially, it's a constellation of symptoms that define the bowel dysfunction that many patients have following rectal cancer surgery. I would also add some patients who have radical radiotherapy, and with the latest organ-preserving radical radiotherapy, some patients get exactly the same symptoms. And that's a constellation of symptoms manifested by urgency, frequency, and clustering still tends to top. If you look at most of the studies in these patients, that tends to top the list of symptoms the patients find very difficult to deal with. So the things that I see patients complain in clinic most of, or the things that affect their quality of life most, are unpredictability and clustering. Patients will also have a degree of evacuatory dysfunction and often have flatus or stool incontinence, which is really significant. And we think probably that anywhere between 60 and 90% of patients undergoing anterior resection will develop bowel dysfunction to a degree. So what are the causes of Lars? So originally we thought that the main reason for developing low anterior resection syndrome was the anatomy, so the loss of anatomical space. But there is probably a less significant component than physiology and gut microbiome effects. So there are issues about neorectal reservoir and potential issues if there is a leak after surgery and consequence of that. But really, it's the physiology that tends to affect the symptoms significantly, and that is the resultant hypermotility of the neorectum, the extrinsic denervation of the distal colon and rectum during surgery, as well as during radical radiotherapy, leads to loss of negative feedback on rectocolonic reflexes. So therefore, rectum is really not able to store as much stool as previously. It's really hyperexcitable and hypermotile. And there is no slowing down of the proximal bowel as with a intact rectocolonic reflex. There's increased number of migrating motor complexes in patients who've had anterior resection, increasing the transit through the colon. And we know that diverting ileostomy causes both atrophy and diversion colitis with significant change in gut microbiome, possibly contributing to some of the symptoms. Chemotherapy and radiotherapy, as I've said, radiotherapy in addition induces anal sphincter dysfunction, and by similar mechanisms really to surgery, leads to nerve inflammation and fibrosis and degree of denervation, but also affects gut wall inflammation and leads eventually to fibrosis. Now, what we know is that there's a significant relation between the LARS score and quality of life of the patients. So the worse, the higher the LARS score, the worse quality of life. So it's a really good screening test in these patients. There are a number of other methods of assessing severity of symptoms, and the issue with all of these is that they're absolutely, I mean, the advantage of all of these is they're absolutely great in identifying patients with significant problems and patients who need early intervention. However, they're not terribly good at reassessing patients down the line often, and we'll discuss that in a little bit. But essentially, the LARS score, which is very simple and straightforward, which tends to be used commonly in this patient group, looks at flatus incontinence, liquid stool incontinence, evacuation frequency, clustering of stools, and urgency. Quite a few years ago, there was we felt was really defining paper, which was an international consensus defining low anterior section syndrome. It's really to try and get a link between symptoms of low anterior section syndrome and then the consequences the patients would have and what they would impact. So rather than just looking at symptoms in isolation, it was looking at the consequences they would have. So, for example, toilet dependence, prescription bowel function, dissatisfaction bowels, etc., which would then have effect on mental health and social activities and relationships, etc. One of the issues in sort of terms of when we look at LARS symptoms is that they're very common, and most elderly patients will defect similar degrees of bowel dysfunction, except of course these patients develop them really virtually overnight and often in much younger patient group. And so of course the holy grail is how can we predict these symptoms in patients? And the Pelican Cancer Foundation has done some amazing work and supported some research by Nick Battersby looking at preoperatively predicting the low anterior section score. And in theory, that would work really well because you could just put the absolutely all the indications, all the risk factors that are acknowledged, and you could calculate the risk of patient getting low anterior sections syndrome. And we know that things like low tumor height and pre-op radiotherapy are particularly important, a particularly increased risk factor. The lovely thing about this work is that they produce these really helpful nomograms which you can share with patients in clinic. We know the patients respond very well. They didn't have to be terribly adept in understanding before they can understand these graphs and look at the risk of developing low anterior resection syndrome. However, it is, despite our best efforts, very difficult to counsel patients before rectal cancer surgery. And this was a study that I really liked. It's been published some time ago now, and it's from Canada, where patients tend to visit both surgeons and oncologists significantly greater number of times than they would do in England. So all patients are seen by an oncologist, and all patients are seen with advanced practitioners and surgeons. And so for this particular study, at each one of these 5 times that they visited surgeons or oncologists or education sessions, the same information was given in terms of cervical cancer, genitourinary side effects and potential complications, and bowel complications. And when the patients were assessed at 6 weeks after, so after the surgery, they brought back to their clinic appointment and asked for recall of what was discussed before their surgery. You can see that significant number of patients were aware either with no specifics of particularly specific outcomes with survival. So people really, really focused on survival from cancer. And even though the patients were told in a script and given the data for sexual function, urinary function, and bowel function, almost 50% of patients claimed that they were not aware of bowel dysfunction. And despite the fact that they were all given a choice between low anterior resection or abdominoperineal resection, none of the patients perceived to have been given an option. And I think that is probably to do with human psychology, in that when patients are given such significant diagnosis, such as cancer, there's very little headspace to focus on anything else. So patients remember everything about a cancer diagnosis, survival, but they don't remember much about other things, which at the time are seen as less important, and they are if you are thinking about your survival as the ultimate ground. But it does make it quite difficult for us to counsel patients appropriately and prepare them for those potential complications they may have after surgery. So how did I manage this patient? And I'm using as an example how to manage most of these patients. Really, I think symptoms are really crucial, and examining these patients in clinic. And part of the reason why I think symptoms are really important is that most general population think very differently about what symptoms of constipation or diarrhea are. Some people talk about constipation when they don't open their bowels for a week at a time, but some people feel just when they can't open their bowel the moment they go to the toilets. It's really important to tease out what exact symptoms are. Diarrhea can mean many things to different people. Some people it's going to the toilet frequently with normal stool. For some people, it's having one-off, slightly looser stool per day. And so it's really important to tease out exactly the right symptoms. The blood tests that I would normally think about doing would be thyroid function test, celiac screen, and B12. And I will often in these patients do a colonoscopy if it hasn't been done locally, and that allows me to examine the perianal area really carefully and assess the anal tone and squeeze pressures, and as well as have a look at the anastomosis and take colonic biopsies if I think there's any chance of an alternative diagnosis, such as microscopic colitis. In patients who've had radiotherapy, do think about bile acid malabsorption, and I tend to try and get a diagnosis first by using a CCAT scan, which we're fortunate to have available, because the bile acid sequestrants are really quite miserable drugs to take. So I sort of don't like, if I can avoid it, just trialing them without any evidence. And I gave the patient loperamide very early on just to try and get him some sleep, because by that stage it was getting quite significant. So he had completely normal bloods, and he had a anastomosis, which was normal at 3 centimeters. His CCAT scan was normal, and with loperamide, he had a bit of better sleep, which meant that he was less tired. Because what lots of those patients experience is quite profound fatigue due to lack of sleep, because they're opening their bowels so many times at night. And actually, as you will all know, there's quite a lot of research out there in terms of lack of sleep and tolerance of many things, as well as impact on mental health. So how would I manage these patients? Well, I suppose I try and split it into trying to manage how to manage the colonic dysmotility. How do I think about neorectal reservoir dysfunction, whether there's any anal sphincter damage, or whether it's a combination of all the above. This is what I referred to briefly earlier. So Bristol stool chart is incredibly important to me in trying to establish exactly what symptoms these patients have. What is it that they mean by when they say they've got diarrhea, for example. Now, because my patient had completely normal blood tests and there was nothing else immediately we can do, and he was still struggling with sleep, I had very early on went on the tricyclic antidepressant medication, which I'm very careful to say to the patient does not work as antidepressant, but it's a neuropathic agent. So a neuropathic painkiller, and calms the nerves down. Patient was incredibly anxious about taking it because he thought I was giving it because he was depressed. And he, in the meantime, had increased his loperamide, claiming they had no side effects, but it wasn't really working brilliantly, and certainly wasn't working on the anti-urgency, and he still couldn't go to the park to take his children out. He eventually agreed to try nortriptyline. And actually, interestingly, he did really well with just 10 milligrams of nortriptyline. And he was able to take his children to the park. And we were just able to get rid of some of that urgency for him. So for him, the main problem clearly was in terms of hyperexcitability of the nerves and a loss of rectal colic reflex. So nortriptyline worked brilliantly. So often I will try, in terms of treating this motility and irritability, I will often try first bulking agents. So psyllium, find it very difficult to get normal now. Fibrogel, I sometimes try, but I don't find it's terribly helpful in this patient group. Some patients can be very sensitive to loperamide, and it precludes its use, and they end up having these vicious diarrhea constipation cycles. But we can get it as a liquid, and sometimes it is possible to titrate up in patients who are very keen. And as I said, tricyclic antidepressants can be really helpful in this patient group. We know that remocetron works really well. It's 5-HT3 antagonist, but we don't have it available in UK, so we can't prescribe it. And although I have used ondansetron in a couple of patients, and just before COVID, we were going to run quite a big trial looking at ondansetron in last patients, but COVID sort of put the end to that. I just don't feel they works as well. What about neorectal reservoir dysfunction? So one of the first things to try and exclude any obvious anatomical abnormalities, and in fact, this is the picture of the very first patient who was ever referred to me, and who actually had anastomotic stricture and numerous fistula coming from it. So really no degree of medical treatment would have helped his function. Particularly in terms of clustering, and there's lots of literature coming out in this, animate and transanal irrigation tends to work really well for a selected cohort of patients. I've got a fairly old kit here, but now it's sort of much smaller and easier to use. And it's just, for some patients, it can really make all the difference. Some patients don't like using it because it can be quite cumbersome. They don't like having it. They don't like the thought of it. And it's a bit of a journey trying to persuade some patients to do it. And then, of course, there's adaptation, and patients, sort of their bowel function tends to plateau at 1 year. Often when I speak to urologists, they're far more generous. They'll talk about, giving a 5-year time for full recovery of function. And interestingly, when you do LAS score in lots of these patients at a year, their LAS scores don't shift significantly, but what improves is their quality of life, which simply means that patients have adapted to a degree. And I think lots of our jobs is to try and help them get to that adaptation stage slightly quicker. I think it is really important to think about looking after these patients holistically. And so pelvic floor rehabilitation does really help. Lots of recent data suggesting they helps in a short-term time frame, so within 12 weeks afterwards. But actually, if you have looked at patients at a year, it doesn't really help. But I think what is invaluable for the patient is to feel like they're in contact with someone. And I think, above and beyond the pelvic floor is seeing someone and getting reassurance that this is a common side effect that many patients experience. I think it's helpful. I won't talk about diet very much because we've got 5 great experts this afternoon talking to us about it. And I'll be looking forward to find out whether anything has changed since I last looked into it. But in terms of management of all patients with cancer who've had cancer, we know the importance of physical exercise and psychological support. And I think, unfortunately, that is one of the things that we tend to miss most of all in the NHS is the sort of these slightly subtler areas which I think improve patients' tolerability with symptoms and their ability to adapt rather than necessarily changing symptoms. So what I would say in terms of, just to conclude, in terms of the management, I like to say to the patients that all the consequences of bowel surgery are really survivorship diseases. So I try and frame it as a trade-off for survival and a trade-off for completely cured cancer. Because there are patients from time to time who are incredibly unhappy and angry with the symptoms. And and probably over my career doing this over the last 15 years, I've had two or three patients who sort of come in and said, I really want to stone my back. I can't live my life like this. And and I tend to frame it that there is always a potential something that we can look to, but we if we've got time and they're patient and they're willing to wait, there are some things that we can do to improve the quality of life, which is what we're aiming for. And one of my very first lines always to the patient is, you will never go to the toilet once a day or anywhere close to what you were like before. It just won't happen. That's unrealistic expectation. That will not happen. What we're trying to do, we're less interested in how many times you're going to the toilet, but we're interested in the fact that it's not affecting your quality of life. So we're trying to deal with the urgency and accidents, so episodes of incontinence and flatus, but rather than aiming for object number in terms of bowel function. So it's the quality of life that underlines everything. And I do say the multidisciplinary management is the key, because I think there are so many different disciplines that working together improve patients' quality of life. Thank you very much.
Thank you so much, Anna. That was a fantastic talk, and you've really shared the benefit of your experience. We will have some questions at the end, but if you, I don't know if you can come back on screen now, but I was just going to comment really just to say that that study about how we counsel patients pre-operatively is really interesting, and something I sort of think about a lot. And it's hard, isn't it? Because I think we all try really hard to do a good job at that, but I don't know how easy it is to do a good job at that for the reasons you outlined. And that study, I thought I hadn't seen that before, and I thought it was really interesting.
I found that really interesting because in such a well-resourced system, I mean, our patients don't get that many interaction, nearly that many interactions. And I remember looking at this with Claire Taylor years ago about when would you intervene and what sort of information do you give? Do you give verbal? Do you give paperwork so they can read away? Do we look at apps? And I suppose I reassure myself with that study because, there were the years when we would say, oh, did the surgeon really tell them? Did they just really see a registrar who didn't counsel them properly? And I think we're probably unfair to some of our surgical colleagues. And I think it's just the human nature. I think, people just can think about survival from cancer. And I guess it's just for us to try and find out when we can intervene a bit and say, hey, well, look, these effects may really be significant.
Yeah, yeah, I agree. The other thing I thought was really interesting was you talked about in that case study about nortriptyline and the success that your patient had with that. So I presume that's something you use quite frequently when you haven't found, an underlying cause, like bile acid malabsorption, etc.
Yeah, no, I didn't want to stray into the other causes because I know that our panelists are going to cover them expertly this afternoon. So I thought he was quite a good example. I tend to use quite a lot of nortriptyline in the right set of circumstances, and it particularly works well for patients who have quite prominent, once you've excluded all the other causes. So once they don't have bile acid malabsorption or pancreatic insufficiency, and the colon looks normal, and the blood tests are all fine, and there's no other reason that you found, is that it tends to work really well in sort of in the states that I tend to describe to patients as sort of hyperexcitable nerves. And I often tend to compare it to migraine. I will often say, when you look at patients with migraine, you do their scans, it's completely normal, but it's their nerves that are being really hyperexcitable. And therefore, it's exactly the same with the bit of the gut, and either gives you abdominal pain, but it gives you that horrible gastrocolic reflex, so you have to rush to the toilet immediately after you eat, or this horrible urgency. And for some people, once you get over the whole, I'm not depressed, I believe you're not making these symptoms up. This is really neuropathic agent. We use it for phantom limb syndrome. We use it for chronic low back pain. It works really well in some patients.
Yeah, that's really interesting. Thank you very much. Thank you. I'm sure there'll be more questions at the
Brilliant.
end.
Thank you.
Thank you. So I'm going to introduce our next speaker now. Um, so Sue Vyoral is a Macmillan oncology dietitian at the Royal Surrey. She's specialised in oncology for the past 14 years, and she became interested in the GI consequences of cancer treatment when she joined the GI nutrition team at the Marsden. At Royal Surrey, Sue has a particular interest in diagnosis and treatment that can affect digestion, absorption, and nutritional status. She's passionate about raising awareness of the importance of nutrition in managing patients with GI side effects of their cancer treatment, and has done some great work in that area. So thank you so much, Sue, for joining us. Over to you.
So hi, thank you very much, Claire, and thank you very much for inviting me. I did watch the session a few weeks ago, and it was really heartwarming to hear Jan and Claire and Sam all saying that a dietitian is a really important member of the MDT, and that is such a good thing to be hearing that nutrition is such an important part of the whole thing. At the Royal Surrey, we unfortunately don't have a late effect service, but also, as we heard in the first session, lots of different disciplines, including ourselves, are actually still seeing these patients. So it's just scattered around rather than being held together in one place. But I think at Royal Surrey there is a recognition and enthusiasm about setting up a service like this, and she's probably watching. Victoria, one of our great CNSs, is really working hard to try and get this off the ground. In terms of service provision, as Anna just said, it's completely different working at the Royal Marsden, and I had the pleasure of working with Anna last year when I went back to cover the clinic. It's just incredible what can be achieved when you have a lot of different specialists in one room and who are all able to see a patient. You can get so much more out of the patient and you can achieve so much more. But I guess what's good from my perspective is that I've seen both sides of it. So for those of you out there who are trying to manage these patients, I do understand how difficult it can be without all of these disciplines at your fingertips. So mine is fairly brief talk. So I'm going to just cover a little bit of background about nutrition and colorectal cancer, and then very, very briefly, I'm covering LARS, bowel obstruction, and my case study is in bile acid malabsorption. And hopefully I've got some helpful resources at the end and I'll flick through them so that if you watch this again, you can go back and see them. So this was a study from Matsil from Sheffield as a cross-sectional survey in the UK of 75 cancer survivors. And basically they were asked about what happened in terms of your diet and nutrition during and after cancer treatment. And some of them had not been given any advice at all. They found any advice they were given was quite conflicting. It wasn't very consistent. And I think we should keep this in mind that many of them found that the advice they were given was quite at odds from the cancer prevention messages that they were all being bombarded with. And they all said that they wanted nutritional advice throughout and following their treatment. And I think this is terrible that 72% of colorectal cancer patients have no outpatient follow-up with a dietitian at all. And Rose Mornsell found that 3% of hospitals that provide colorectal cancer services didn't have a dedicated colorectal cancer dietitian. So it's no wonder that patients try to work out what to do for themselves. So these were all studies in patients who've got bile acid malabsorption. And many of them are trying to exclude lots of different things that they think might be a problem or that friends have told them or they're looking on the internet. So Banniger found that patients were actually restricting many things, fats, gluten, wheat, lactose, carbohydrates, and many of them were trying to exclude a number of these all at once, which is incredibly difficult, very depressing, and people aren't able to eat in the same way that their friends and families are. Avoiding fruit and vegetables is really common, but we know what that can do on the basis of a nutritional consequences. And Sarcher and Bold study was in a smaller number of female patients with bile acid malabsorption, and they were saying that it wasn't just the GI symptoms that were taking a toll on their mental health, but the whole issue about worrying about the fact that they just don't have a balanced diet anymore. And obviously all of them are risking deficiencies by not doing this with a professional support. But if we can manage to see these patients, and Jan mentioned this in the first session, that as we all know with these patients, and Anna has mentioned as well, that taking a good history of symptoms is really important. And for us, taking a good symptom and food history is essential. So when we first meet a patient, we might often, in other circumstances, say, oh, what did you eat this morning? Or what did you eat yesterday? But with these patients, we will never ask them what they ate yesterday or in the last 24 hours, because if they're coming in to see us, you can be absolutely certain that what they're eating is not what they normally would do, if indeed they've eaten anything at all. Because many of them are so scared that something is going to happen en route to the clinic, they're going to have an accident. So often people just won't eat anything at all. So we want to know not just what they're eating now and what they're drinking now, their patterns of eating, how much they have, and how this all compares to what it was like before their diagnosis or their treatment. Do they avoid anything? Do they think there are certain food triggers? But I think those questions need to be sort of listened to, and we're going to assess them. But quite often people attribute symptoms to completely the wrong foods or the wrong meals, and we'll mention that a bit later with bile acid malabsorption. I think it's also really important to ask them what diets they may have already trialed. So lots of people will have tried things like gluten-free, or they've taken out dairy or lactose. They may have read about the low FODMAP diet. And then, was that effective? And quite often it wasn't. But then the next question should always be, so then have you reintroduced foods and stopped the diet? And quite often they haven't. So as time goes by, they exclude more and more things, but to no avail and to a much poorer nutritional consequence. Obviously, we asked them about weight now, what weight was like before, about their strength, and about their whether are they still able to do things that they were able to do before. So if they played tennis before, are they strong enough to still continue to do that? Because we need to find out not just about weight, but about what's happened to their muscle mass. And then thinking about other conditions. So do they have anything else in their past medical history, like celiac disease or diabetes, or they may be vegetarian, which needs consideration alongside all of this. And then sometimes we'll ask people to keep a food and symptom diary, which is incredibly useful, but it's really, really difficult to do it, or do it to the level where it actually really makes sense. But if a patient's willing to do it, then the one thing that's very important is that we take the time to analyse it, so that they don't come back into clinic and find that we haven't really done very much about it. So this is incredibly brief. I would have liked to have spent a bit longer on this, but we spend a lot of time trying to understand diet and symptoms in these patients, and taking a detailed nutritional assessment is really key. And as Anna mentioned, they're much better managed in a multidisciplinary setting, and they have a lot of issues. So it's often very important to really concentrate on the particular ones that are really affecting and troubling them. So it does need to be very individual. There is evidence out there for different things, but I wouldn't say that there was a huge amount of robust evidence. So the first line advice often is about reducing what they're eating in one sitting. So making their pattern of eating and drinking more frequent. So eating more slowly, chewing their food really well. So things like having large volumes of fluid all at once can lead to looser, much less easily controlled stool movements, but really focusing also though on sipping frequently, often ensuring that they remain well hydrated. Colonic motor activity increases with larger volumes of food or fluids and can lead to urgency. It's better to have still fluids rather than carbonated ones. And also, there's a lot of talk about reducing caffeine, but there's some older studies that say that it isn't just the caffeine in products like coffee, it's actually some of the other properties in coffee that can also lead to some of these symptoms. So I would say that if stopping or switching to decaffeinated. If that doesn't seem to work, then I would ask them to do a trial of no caffeine at all, decaffeinated or either otherwise. So people often find that alcohol leads to urgency, and more sort of fizzy alcoholic drinks like beer and lager can lead to flatulence and bloating. So second line advice, which probably more ideally a dietitian would work with them, because fiber's really quite complicated, and we talk in terms of soluble and insoluble, but it is a bit more complicated than that. But often moving more to a soluble fiber can improve consistency and reduce frequency. And in some studies, they found that it can be beneficial in decreasing clustering. And we have, I think, a really useful booklet called Low Irritant High Fiber, which is freely available on our website that we use in these patients a lot, and also in lots of other patients. I mean, obviously, anybody who's eating a very low fiber diet, fiber needs to be introduced slowly, because even in someone without any problems like this, moving from no or low fiber into a high fiber diet can cause a lot of problematic symptoms. So as Anna mentioned, commonly they will have bile acid malabsorption, so fat can often be a problem. So I think we need to watch out for that and question them on when they feel that they're getting symptoms following eating a high fat meal. Certainly in studies when they've asked patients what they think triggers problems, many of them will talk about fat. So sometimes we can reduce that a little bit to see if that improves on frequency, urgency, and loose stools and incontinence. And sometimes people have considered the role of fermentable carbohydrates in terms of bloating and flatulence. And so with some patients, some dietitians use the low FODMAP diet. I haven't. I know dietitians that have. But I think even the dietitian at St Mark's hasn't used the full low FODMAP diet. On the Monash website, which is actually in my references, there's something called FODMAP Gentle. So if you were even vaguely thinking that there may be some foods that are a problem, if you look at those, there's just a few that can be reduced or removed that isn't going to cause such a major dietary rehaul as the full low FODMAP diet. We obviously have to consider the patient's own trigger foods as well and take those into account, and always at the back of our minds be thinking of bile acid malabsorption, small intestinal bacterial overgrowth, and pancreatic insufficiency. So I'm just going to talk a little about bowel obstruction. So this really should only be undertaken by a dietitian, because it's incredibly difficult to do this without maintaining a nutritionally adequate diet. But I work with Lindsay Allen, and she has been working with patients with bowel obstruction for many years, and actually did a feasibility study which was called Bounced. It's a very small study. Many of the participants were colorectal cancer patients. And it was really to test whether patients could actually use this diet. And essentially, it goes through 4 different steps. So quite often, if a patient has been admitted with bowel obstruction, they will be started on clear fluids, and then they might be moved across to thin fluids, smooth puree, and then our step 4 is the one which is basically soft, sloppy, melt in the mouth. But probably differently to many other bowel obstruction diets, this removes all bread products completely, because it has been found that these can be a real problem for these patients. But interestingly, most of the patients in this study found that it was a really fairly easy diet to actually follow once it had been explained to them. They were eligible to go be enrolled in the diet if they had pain, bloating, early satiety, nausea, and vomiting. And apart from the fact that they found the diet quite easy to use, it reduced their symptoms of bowel obstruction. Crucially, and I think financially, if we're trying to think about things like that, it reduced admissions to hospital considerably and improved quality of life. It does take quite a while to go through this. We use funnels to try to explain how rigid sometimes it can be to actually, and how small an area they can find within inside to actually get food through, and why something needs to be very soft, sloppy, or even a fluid. Many will need nutritional supplements. And if patients are stable on their final step 4, they're not symptomatic, then we can start to think about introducing some soluble fibre very slowly, and also consider having some toasted bread products, which patients are usually delighted about. And obviously, if their symptoms return, then they need to go back to step 4 again. So patients can take themselves back and forth through the whole diet. So I just wanted to move on to Shirley, who's my case study on bowel acid malabsorption, and Shirley isn't her real name. So Shirley was 73, married. She had a daughter, twin grandsons that she absolutely doted on. And she was a retired travel agent. So this was a lady who spent a lot of her adult life traveling. So when she was 60, she was diagnosed with cervical cancer and had chemotherapy, radiotherapy, and brachytherapy. She's got hypothyroidism on levothyroxine. And so after her treatment for cervical cancer, her symptoms never really went away. And she was one of the patients that we read a lot about in studies who went back and forth to her GP. She was eventually commonly diagnosed with IBS. But then none of the strategies that she was trying to deal with the IBS seemed to be working at all. So she was looking at different charity websites and seeing if there was anything out there for people like herself. And she went back and, I mean, luckily she was somebody that went back and forth and badgered her GP into referring her to a gastroenterologist. She didn't actually find him that helpful. He didn't seem to be particularly interested in the fact that she actually had had cancer or treatment. But he did do a CCAT scan, and she was found to have moderate bowel acid malabsorption. He prescribed her 2 cholesevelam a day. But then not that long afterwards, Shirley moved out of area to go and live near her daughter, and she didn't sort of bother having follow-up. But then she was diagnosed with a second colorectal cancer. She had a hemicolectomy and Capox chemo. So she was still having a lot of problems. One of the consultants did some bloods, and she was found to have extremely low vitamin D. So she was given an acute replacement for that. Her B12 is in normal range, but it's definitely down the lower end of normal. And I mean, she may well be somebody that will need ongoing B12 replacement, but that will need to be monitored. So when I first saw Shirley, she had horrendous bowel symptoms. She was wearing incontinence pads, which she absolutely hated. She particularly hated the fact that she had quite incontinent, like flatulence and stools. She was spending far less time with her grandsons because she was just so mortified if anything happened when they were around. She was still taking colosevelam, but she was taking it at breakfast time. And she was taking loperamide, but only if she had a watery stool, which was quite frequently. So she had already cut out most fruits and vegetables since her radiotherapy. And if you read anything about women after gynae cancers, many will use cutting out fruit and vegetables as an attempt to control their symptoms. She thought dairy made things worse, so her daughter said, look, just cut out dairy because I think it's really bad for cancer anyway. She looked on the World Cancer Research Fund website where they said about having red meat once a week. And as we know, a lot of patients take advice to extremes. So she just felt that by stopping meat altogether, that had to be a much better move. And looking at fibre and colorectal cancer, she decided that she really needed to have a lot more fibre in the diet. So suddenly took herself from very low to a very high fibre diet. So she was pretty miserable, just really had no idea what she was supposed to be eating anymore. And I think everyone has mentioned this kind of thing, what matters to a patient. And Shirley had this real dream of taking her grandsons to Efteling, which I had never ever heard of. But she just saw that as an opportunity to go abroad and take her grandson somewhere that would be really just amazing. So we looked, she was put on ongoing vitamin D supplements. Um, as you probably all know, with most, especially dose critical medications, you need to leave a 4-hour gap between those and colesevelam. And she was taking thyroxine first thing in the morning, but then having a colesevelam with breakfast. So she could have taken that at lunchtime, but she chose to take it with her evening meal. And also, bile acid sequestrants bind really, really well to fat-soluble vitamins. So we needed to move that away from her vitamin D supplement as well. So we asked her to try and increase her colesevelam by 1 every 2 weeks. And what's the evidence for that? Probably none. But we can't review people that quickly. So it's more pragmatic because we just need them to be able to increase by 1 or 2 and then we can review them. And as Anna was talking earlier about the fact that patients don't remember all the discussion about a diagnosis, I just find that it doesn't matter how well somebody has explained bile acid malabsorption to them, you always have to repeat it again. They just don't really, it's quite a difficult concept to take on board. And I think this is just the most important thing, if you don't know it already, but to discuss with a patient is that if they have a lot of fat on one day, the symptoms are going to be 12 to 15 hours later. And I think this is where a lot of patients attribute the wrong foods to things, because they'll say, oh, I can't eat dairy because every time I have my cereal with milk, I just rush to the toilet, or when I eat tomatoes, I rush to the toilet. But it's not that. It's probably the pizza takeaway that Shirley had with her grandsons the day before that caused the problems. So we also moved her loperamide to take 30 to 40 minutes before a meal or going out to help slow down the gut. But then we found, or Shirley just found, that she just couldn't increase her colesevelam because she just didn't tolerate any more than 2. And always at the back of our minds, we're thinking of the overlap between all of the other conditions that she may well have, especially having had 2 cancer treatments. So we then started talking to her about whether she would trial a low-fat diet. She really wasn't keen, but she said, okay, I'll give it a go. And we agreed on a time frame of 6 weeks to see what happens. But the thing is that you have to spend a lot of time with patients to help them actually to do that. It really takes a long consultation. And the other really important thing, I think, for patients to appreciate is that people will say to me, but I eat really healthily and I don't eat, bad fats at all. But actually, when you look at what Shirley was eating on the left-hand side, her diet was very, very healthy, but there was a lot of fat in there. And bile acid malabsorption doesn't discriminate between so-called good fats or bad fats. And interestingly, Shirley was only eating like that because she thought it was healthy. She was finding it incredibly expensive to eat like this. And probably more importantly, her husband didn't eat like this at all. So we talked about how she could change things that wouldn't be too onerous, but would mean a switch and a huge reduction in fat intake. But we made sure that she had things in it that she wanted, like some cheese snacks and cheese. But we talk a lot about label reading and alternative ways of cooking. So things like putting vegetables in a freezer bag with a little bit of oil, shaking it up with some herbs, you're going to use a lot less oil that way. And we also made some of her really tough insoluble fibre into a more soluble fibre. So we can't ignore the fact that some patients actually do want to leave the house and want to eat out. And so there's a lot of really good nutritional information out there on supermarket websites and chain websites. So it just means that they can make much more lower fat options if they want to. So Shirley now, her bowels have improved considerably. She still wears incontinence pads, but I think she just said, I think it's just because I just need that confidence. She's taking the colesevelam and the loperamide more appropriately. Her diet is much more like the rest of the family, and she manages things much more easily now because she's much more careful about the dietary fat that she eats on the day before she wants to go out or the day before she wants to spend time with her grandsons. And she's just got more control over her diet. And amazingly, they made it to Efteling in the Easter holidays. And I mean, that is such a great achievement. So I think consider a referral to a dietitian in these circumstances. So if a patient's underweight, losing weight, already malnourished, or if you feel that they're at risk of vitamin and mineral deficiencies, history of disordered eating, if they're already restricting their diet so much, and if patients have really poor nutritional knowledge, they can't see, they don't have any cooking facilities, or they're a carer. Under those circumstances, I think get us involved and we'll try and help them, or if they've got complex dietary changes to make. And also people that have a lot of other comorbidities, or where we need to take into account other diets, we can help there, I think. And I think our aim is really to improve their symptoms, but at the same time, make sure that their diet is nutritionally adequate. We always have to consider the consequences of what it means to change someone's diet. Try not to change too many things at once. Make sure there's a time limit on everything that you do and follow them up, because patients really take things to heart and will run with it sometimes. And we have to review and adapt things if they're not working very well. It takes time with patients to counsel and with behavior change. And quality of life is paramount, not just in terms of their symptoms, but also managing a diet, but living a decent life. And so these are just some resources that may be helpful, so you can skip back at them afterwards and have a look through them. And we've got some references there, but I think Bowel Cancer UK said that you could have them if you wanted to. So thank you.
Thank you so much, Sue. That was a fantastic talk, and really highlights, I think, how you can't do this without a dietitian. I know I always say that, but you absolutely can't. It's you really need that expertise of a dietitian, that when you're trying to help patients manage these symptoms. Just a couple of comments. I know we'll have questions at the end, and I know that some are coming in, but just to say that. So you make a really interesting point about patients attributing their symptoms to like the wrong meal, because we don't explain, or they don't remember us saying how long it takes for the effects. And I think that's a really important learning point when you're talking to patients about this and trying to help them manage symptoms. They really don't understand that or remember that it was that pizza. I've had nothing today, and yet this has happened to me again.
Yeah.
I think that's a really important point. And just say I know that you and I are going to collaborate in our clinical areas, but we have tried the FODMAP diet for some patients where we've been really struggling, and I mean, it's hard for them, but it has really helped for a couple of patients. So yeah, it's interesting, isn't it? We're getting more and more evidence and more options, I think.
And I think that, I mean, that gentle FODMAP, I think, is a really good thing to bear in mind, because you don't to do the low FODMAP, you really need a specialist dietitian. But the gentle one is just a few things that you can think of and try with a patient if you don't have access straight away to a dietitian.
Yeah. Thank you so much, Sue. I know we'll see you again a bit later on for the Q&A. That was a great talk. Thank you. So now we move on to a session on sexual rehabilitation and support after colorectal cancer with Dr. Isabel White. Dr. Isabel White is a psychosexual therapist at the Royal Marsden. She's a cancer nurse by background and a senior accredited psychosexual therapist working in a specialist cancer centre on a voluntary basis for Maggie's Cancer Charity. She provides psycho education and sexual therapy to people whose sexual lives and intimate relationships have been adversely impacted by cancer and its treatment. Thank you so much to Isabel for joining us and covering this really important topic.
Lovely. Thanks ever so much, Claire, for that kind introduction. It's really good to be with you this afternoon. And I suppose it's quite intriguing, isn't it, to think about bowel cancer and late effects. And then would any of you automatically think to include sexual rehabilitation as part of that, of a late effects service? I think increasingly we are becoming more aware of the importance, particularly when we're managing cancer in the pelvis, of the interrelated nature of the different organs and systems that are in that part of the body, and the importance, therefore, of not focusing solely on things that are perhaps a daily concern, but actually thinking about things that may also impact people's quality of life and relationships that aren't necessarily a daily concern, but are certainly a concern on a weekly or a fortnightly or monthly basis. So let me just see if I can move these forward. Yeah. So I think the first thing to say is that when we think about sexual difficulties after pelvic surgery or pelvic radiotherapy, certainly when it comes to men or those who are born male, we're often focusing predominantly on erectile dysfunction. But I think what this diagram illustrates is the importance of us thinking about sexual well-being across all different stages of the human sexual response cycle. So not just thinking about arousal difficulties, which is where erectile dysfunction comes in, but also thinking about the impact on people's desire, on, yes, people's arousal, but also thinking about changes to orgasm and a sense of change in terms of sexual satisfaction. So what this diagram illustrates, I guess, are the multiple impacts at different parts of the human sexual response cycle that are created by colorectal cancer treatment. So desire is often affected not just by psychological issues, but also by changes perhaps in hormonal levels as well. So yes, a lot of it is around altered femininity, altered masculinity, body image changes, and that may or may not involve changes associated with stoma formation, but also thinking about hormone imbalance in terms of a reduction in testosterone and or a reduction in estrogen impacting someone's levels of desire. And then also, really importantly, when we're thinking about particularly bowel disruption, is the impact that bowel and urinary continence and control issues have on the confidence that people have to be sexually active and to have a sense of sexual well-being. So even if their actual sexual function hasn't been adversely affected, there will be an impact arising from sexual difficulties arising from changes in bowel and urinary control. If we're thinking about then the arousal phase, and here obviously where we're looking at individuals who are born male and have male anatomy and physiology, and we're thinking particularly about the ability to obtain and maintain an erection to be able to complete intercourse. For those who are born female and identify as female, then here, particularly if you have female anatomy in the pelvis, then you're thinking about changes to the vagina in terms of dryness, shortening or narrowing of the vagina, particularly as a consequence of either pelvic radiotherapy, or indeed if you're having more extensive resections, again, changes in terms of there being a narrowing of the vagina as a consequence of surgical resection. And again, also, if we're removing other parts of the organs in the pelvis, and here we're thinking particularly of low rectal cancers being excised, and you remove the rectum, you also can sometimes get a change in the actual position and lie of the vagina, whereby there's not the same cushioning with the rectum directly behind the vaginal wall. And so you can then find that the vagina actually changes its position, and that in itself can also lead to sexual pain. From an erectile dysfunction point of view, we're mainly looking at either pelvic nerve damage, or indeed we might be looking at changes in blood flow as a consequence of surgery and or radiotherapy, bearing in mind, of course, that many individuals are having more than one treatment. When it comes to orgasm, again, main culprits here are pelvic nerve damage, either resulting in retrograde ejaculation in men, where the ejaculate, instead of coming outwards through from the tip of the penis, actually goes backwards into the bladder. It doesn't cause any harm, but obviously it's important from the perspective of the loss of ejaculation and also any implications that may have for fertility options. There can be, particularly after pelvic radiotherapy, a reduction in semen volume. And again, that can be relevant to many individuals in terms of how that changes the orgasmic sensation, but also can be important in terms of particular sexual relations where ejaculation as a sign of outward orgasm and enjoyment is then absent because there isn't the same amount or there is no ejaculate coming out. And so again, there can be changes in the intensity and immediacy of orgasm, but also there can actually be a complete delay or an absence in orgasm too. And then in the resolution phase, where things are going back to that kind of pre-arousal state. Again, pelvic congestion, where there's a sense of heaviness and incomplete drainage, if you like, from the vasculature in the pelvis. There may be where the vagina has been irradiated, there may be bleeding after intercourse because of damage to the mucosal lining. There may again be pain after intercourse and overall reduced sexual enjoyment. So let's look specifically then at changes in male and female sexual function after colorectal surgery. There are definitely higher rates of sexual dysfunction after the deeper and lower pelvic surgery. Where you're going for very low anastomoses, you're more likely to see sexual disruption than those who have resections that are higher in the pelvis. And again, bearing in mind that AP resection carries a greater risk of sexual difficulties than anterior resection. And again, if you combine radiotherapy and surgery, which we regularly do for patients treated for rectal cancer, then again, that combination also increases the risk of sexual difficulties post-treatment. And you can see very high levels here of women reporting sexual pain after pelvic surgery. So almost 50% of women experience sexual pain as a consequence of their AP resection. And again, more likely to have problems after AP resection than after anterior resection surgery. About 56% of women in this study reported inadequate vaginal lubrication, again, related to nerve damage. And if they've had radiotherapy, again, that can be a consequence of pelvic radiotherapy, that we don't produce the same amount of vaginal lubrication, even when we're aroused and turned on to sex. And again, there are some individuals who find that it's difficult to orgasm, or it takes a lot more sexual stimulation to reach orgasm, again, caused by changes in the pelvis arising from either nerve changes or indeed changes in blood flow. And interestingly, even in those without a stoma, about a fifth of men and over half of women said that bowel problems were affecting their sexual life. So again, looking very closely at that relationship between bowel function and bowel control and the actual ability to feel confident in being sexually intimate. And again, as was mentioned previously at the beginning of these sessions, the importance of looking at the psychological effects of both the diagnosis and the surgery, because again, the prevalence of anxiety and depression can also have a negative impact on sexual desire and the frequency of sexual activity. Here's another study looking at individuals about 2 years after colorectal cancer was diagnosed and treated. And again, the majority had been treated for a colon cancer rather than a rectal cancer in this particular study. So about 54% of this group of patients had reported decreased sexual desire, and about 2/3 of them reported a decrease in the frequency of intercourse. But actually, even though that was the case, about 2/3 of them were still having intercourse at least once in the past 2 weeks. So there might have been an overall reduction in frequency, but they were still being sexually active on a semi-regular basis. About 48% had a decreased ability to reach orgasm. And again, those after rectal cancer had greater problems with desire and orgasm than those treated for colonic cancer. And not perhaps again surprisingly, those who experienced fecal incontinence 2 years after diagnosis had decreases in all different stages of their human sexual response. Interestingly, and again, unfortunately not a surprise, only 16% of patients had actually had a discussion about sexual well-being with their medical team, and only 10% of patients initiated discussions were actually about sexual concerns. So important for us to recognise that patients themselves are often reluctant to raise this as an aspect of their aftercare. And discussion rates were lower for women at only 11% with after colon cancer compared to men. And again here, so a higher prevalence of discussion after rectal cancer than colon cancer, but a gender difference here in terms of lower incidence of discussions happening for women compared to men. And again, this is predominantly because of the focus that we have on erectile dysfunction, because again, we've got medication that we can readily prescribe to help with that. And factors that increased the likelihood of discussion happening were things like people being under the age of 55, having a stoma formed, or indeed receiving pelvic radiotherapy. So something that I often talk about is us thinking about the introduction of a step level model of sexual rehabilitation and support. So if you were thinking about, much in the same way as Sue was talking about steps that you can begin to take, even if you don't have access to a dietitian, what we must remember is that not everybody needs to have a psychosexual therapist as part of the team to necessarily meet their sexual well-being needs. But it's about thinking about the different levels of complexity and information that we could deliver through different parts of the multidisciplinary team. So here we've got a 3-level model where level 1 is what we would call universal supported self-management strategies. So I would say that individuals like yourselves who are specialist nurses and therapy radiographers and other allied health professionals are very much in a position where they can offer that level 1 sort of permission giving and limited information about the types of practical support that might be beneficial in the presence of bowel cancer treatment and disruptions to sexual well-being. So here talking about things like pre-sex stoma care in terms of emptying the bag before actually attempting to be sexually intimate, securing the bag so that it doesn't flap around. That might be using a cummerbund, or there might be other mechanisms, or indeed if it's an end stoma, it may be wearing a stoma cap, for example, rather than a bag. Thinking about different body image adjustments that can be made that allow people to express themselves sexually, but without necessarily showing their full abdomen or pelvis if they're feeling inhibited by either the presence of a stoma or indeed the presence of scarring. And then thinking about things like vaginal and anal dilators and their importance in terms of being able to maintain the patency and the stretchability of either the vaginal cavity or indeed the anal cavity. Looking at being able to give proactive advice about intimate lubricants and vaginal moisturizers, which are particularly important in women. And again, thinking about lifestyle guidance that is both gender specific and sexual orientation and lifestyle specific. So thinking about individuals who may be in a same-sex partnership, whether that be a gay man or indeed whether that be a lesbian woman, and the types of lifestyle that they're engaged in, and then being able to modify some of our guidance so that it actually fits with their lifestyle. Also, don't forget, it's really important to be able to give people advice about safe sex and contraceptive advice, again, in terms of what they should be avoiding in terms of types of sexual behaviour, which might increase the risk either of a developing infection or indeed actually cause problems for them in terms of sexual expression and control. And then that second level, if you like, is more for high-risk case management strategies. So that might be for people who are advanced nurse practitioners or senior therapy radiographers who perhaps have a particular interest in sexual recovery and rehabilitation, and thinking about giving advice about where to get help for erectile dysfunction in terms of erectile dysfunction services, or going back to their general practitioner to be assessed with a view to being prescribed oral medication, for example. And then where those things don't work, it may well be then looking at things like vacuum erection devices or intracavernosal injection, which we'll come on to some examples of interventions in a moment. It might be about developing some psychoeducation programs, whether that be face-to-face or online, again, just to give people guidance about why sexual disruptions are actually happening as a consequence of this particular treatment, because we become understandably very focused on the bowel and possibly on what's happening in terms of urinary disruption, but we may neglect to think about what might be happening from a sexual disruption perspective as well. It may be that, again, if we've had additional training and we feel confident about raising these topic areas with people, that we can think about advice on the use of vibrators to help with stimulation, the use of cock rings to help maintain an erection that might not be able to be maintained on its own until the end of completion of intercourse, or indeed giving advice about preferred sexual positions that reduce depth of penetration if there is sexual pain, for example. And then the third level, if you like, is this high complexity case management strategies. And that's usually in the province of a psychosexual therapist or a psychologist that's undergone sexology training, or indeed a medic that's undergone sexual medicine training. So generally, we're looking predominantly at emotional and physical comorbidities that might be making someone particularly vulnerable to sexual rehabilitation and recovery. It might be that there are couple dynamics that are, again, maintaining the difficulty that may predate the actual diagnosis of cancer and cancer treatment, or it may be that there are complex sexual lifestyle issues and sexual or gender identity challenges that, again, are better managed by individuals who are used to working with these types of challenges, and being able to see someone therapeutically over a series of sessions so that there's time to help them actually progress things from a cognitive and behavioral point of view. I think it's also worthwhile remembering that much of your work as specialists working in colorectal and bowel cancer services is about the psychoeducational role that you have. So helping people understand whether the change is either transient and likely to recover, or indeed whether it's more permanent change in sexual function, and then exploring what that means for their adaptation. Again, it's also about promoting healthy couple behaviour and lifestyle behaviours. For example, the importance of mutual respect, being able to respect individual and couple boundaries in terms of what sexual behaviours are acceptable and what adjustments may be acceptable or not based on people's religious background and cultural background, etc. But again, focusing very much on how we can support couples to communicate more effectively with each other, but also bearing in mind the importance of general health and well-being for sexual function, such as exercise, fatigue, and weight management being an important part of that story as well. And then, of course, last but by no means least, we're thinking about the kind of functional adjustments that are important in relation to both urinary and bowel control, body presentation options, again, to disguise the presence of scars, the presence of stomas, if people are embarrassed or finding it difficult to be completely naked, either with an existing or indeed with a new partner. This is a study that was recently published, which was particularly looking at use of the PLICIT, or an extended PLICIT model, sexual counselling intervention. And although the focus was around women with a stoma, actually a lot of these principles would apply to both genders and to those who might present as being non-binary. So again, here we're looking at helping people express their thoughts and emotions around their sexuality after they've had colorectal cancer treated or indeed had a stoma formed, and being proactive in asking questions such as, has the stoma actually affected your sexual life, and what changes have you noticed in your thoughts and feelings about sexuality since you had your stoma formed? And then at the limited information level, it's things about explaining to individuals why normal sexual function has changed and what alternatives there might be, for example. So these are just, again, examples of where we might actually offer more guidance with regards to sexual management, if you like. I'm very aware of the time, and I think I'm almost out of time. So I'm just going to quickly speed through these last few slides, bearing in mind, obviously, that, again, we're often making cross referrals for individuals who need additional support for erectile function. And these, again, are the range of biomedical strategies that can be used and device strategies that can be used to help with erectile dysfunction. And these can be found through an erectile dysfunction service, or indeed through a andrology service, or through the patient's GP. And then from a vaginal health perspective, again, thinking about non-hormonal vaginal moisturizers, the importance of local estrogen and systemic estrogen if the person's been thrust into a treatment-induced menopause, and the importance of the use of intimate lubricants as well, to actually help with sexual activity and reduce friction, particularly after pelvic radiotherapy. But also thinking about things like the use of dilators, the use of vibrators to increase blood flow and arousal, and also the use of devices like the O-nut to actually reduce the depth of penetration, so that sexual pain is less likely to occur if the vaginal anatomy has been altered as a consequence of pelvic surgery or radiotherapy. And again, thinking very much again about body presentation and about lingerie and underwear for people with stomas, to again help them feel more confident in being able to express themselves and express their sexuality in the presence of being in an intimate relationship. These are just some sources of additional support for sexual difficulties, which you can look up and which are important for patients to be aware of. But unfortunately, all of these services now actually have a cost associated with them. So again, the most easy, well, it's not easy, but the way to get access to a low-cost option would actually be to get referral to an NHS service. But these, unfortunately, often have long waiting lists. And I think, just in summary then, this is very much the practice challenge for all of us. It really does still remain our responsibility to raise the topic with patients and their partners, and it's not the patient's responsibility to pluck up the courage and ask the question. So I think all of us can think about actually finding a form of words to ask one question in clinic and when we're reviewing people, to find out whether or not they have sexual concerns or difficulties, and indeed, would they actually like help with anything. Again, thinking about what you can provide, but also thinking about what services you might have in your locality so that you can actually make cross referrals. But the key thing here too is thinking about the things that we can be proactive around. So things like vaginal health and menopause management, hypogonadism and erectile dysfunction management strategies, and making appropriate supportive care recommendations and referrals in either primary or secondary care settings. And I think that's me. Thank you very much for your patience and attendance.
Thank you so much, Isabel. That was a fantastic talk. Really, really informative, and with some really practical advice, which I think, I know there'll be some questions at the end, but I think as specialist nurses, that's what we really need, just to give us the confidence to address this. And I'm sure there will be questions at the end, and I'll move on in the interest of time. But just to say that I was having a conversation with someone yesterday, who I think is probably watching now, and we were saying about, you feel like you've got nothing to offer to patients, and that's part of the reason that you don't ask, because you think, what will I? So giving us some of those tools is so valuable. So thank you very much. I'll move on, and we'll have questions at the end. Thank you. So our final session is on cancer-related fatigue, and will be delivered by Rose Marshall, who's the clinical lead occupational therapist, and Nicola Peat, who's a consultant physiotherapist, both at Guy's and St Thomas's. And thank you both very much. So Rose leads the cancer and surgery OT acute inpatient services and outpatient rehab clinics. And she's an accredited level 2 professional coach undertaking a psychological therapy diploma, centered around behaviour change approaches. Nicola leads the physio, inpatient and outpatient cancer, prehab and rehab and clinical physical activity and exercise service at GSTT. Nicola completed clinical academic pre-doctoral fellowship with the National Institute of Health Research, where she completed her master's in research, exploring the lived experiences of physical activity and exercise in cancer patients undergoing immunotherapy. What a great, interesting topic. Thank you both very much, and I'll hand over to you.
Thank you so much for inviting us. We're really happy to be here today. So I'm Nick, and then my counterpart is Rose, who's the occupational therapy lead, who's on the call here today, and you can see a picture up on the screen. So I think one thing to say that myself and Rose have probably worked with each other for over a decade, I would say now. And we do run the inpatient and outpatient services. And on the next slide, I think you can see where we're based. So this is at Guy's Hospital, and we do have inpatient and outpatient services based next to each other on the same site. But basically, we support people before, during, and after treatment. We work with patients recovering from all major cancer treatments, helping them manage a wide range of symptoms, but perhaps more than anything else, we help people manage particularly fatigue. And we do run specific and dedicated programs for fatigue for those with cancer. And so hopefully today we can share some of the practical strategies we use in our practice and that you might find helpful in yours. So let's start with the most important question, and that is, what is fatigue? Now, what's going to say that we did a thumbs up? I'm not too sure how Zoom works, so I'm just going to say some phrases that we commonly will hear patients express about what they consider fatigue to be, and see if this rings a bell with you also. So often we will hear exhausted, I'm drained, I feel shattered, I've got no energy, I feel foggy, feel quite heavy, like as in my body feels heavy, lethargic. And then we might hear the term tired as well. But what's interesting that we rarely hear probably tired on its own. It's always coupled with one of the former sort of descriptors. So hopefully that rings a bell with you too, in terms of what your patients talk to you about. And what we know is cancer-related fatigue is one of the most common and distressing symptoms experienced by our patients. You know, studies do show 70 to 90% of patients will experience it, and at quite significant sort of levels. And that will be at some point either during or after treatment, although we know the prevalence can vary depending on the treatment stage someone is in. And it really is a subjective experience. That's it. It's individual to that person, that individual going through it. So for many people, we will hear that fatigue begins before treatment has even started, and often then it will worsen as they go through treatment. And for many, they may recover post-treatment, but for some, that fatigue really stays on, and it continues months and even years after the treatment's finished. And the important thing is that it isn't normal tiredness, it's beyond that. We're all familiar with, if we're feeling tired after a busy day, when we've been at work, or we've had a poor night's sleep, usually after a good night's sleep after that, we feel refreshed. What our cancer patients will say is that actually this doesn't work for them. They feel like a bone deep exhaustion. Rest helps a little, but it doesn't completely restore it. And so it's really disproportionate to the amount of activity that they've actually done. So things like making breakfast, walking upstairs, taking a shower, or simply concentrating during a conversation can feel really totally exhausting for them. And I would say for people with bowel cancer, there is often additional challenges. So the causes of fatigue in general are multifactorial. There's not just one cause, but there'll be some specifics to bowel cancer that we need to take note of. So Rose, can you just go to the next slide? So imagine someone who's recently gone through major treatments, so whether it's the surgery or it might be the chemotherapy, radiotherapy. There are often, effects from the cancer itself, and there's an inflammatory process that we have to remember they're going through. So that's a physiological effect that can be a causation to fatigue. There's the treatment itself, and we have to remember the treatment doesn't only affect the cancer cells, it affects the healthy cells, and that can create some repair processes that are going on in the body. So along that with some hormonal changes that can be attributed by the treatment. This creates a really metabolic and energy consumption imbalance. So we've got an instability there that the body's having to deal with already just through the cancer and its treatments. And then perhaps someone is adapting to maybe a stoma. Like we just heard from the previous talk, there's a lot of thin factors going on with the consequences of the treatment that need to also be considered. Someone can still be recovering physically. It might be their appetite hasn't fully returned. They might be in pain. There's bowel absorption and motion changes. We often will hear from our patients, they've often had to wake several times each night, so they've got interrupted sleep pattern due to bowel frequency and urgency. And they could be anemic from the treatment that they've had or have a B12 deficiency. They're all attributing factors to fatigue. So I think what we have to be really mindful of that is a combination of physical and psychological factors that can be going on. We've got to think about the anxiety effects alongside what's going on, alongside this as contributing factors too. So I think for us as professionals, it's really trying to, one thing for us is how we validate that when a patient expresses they've got fatigue. One of the most powerful things we can do is actually, how do we validate that this is a real symptom? And often from particularly the psychological side, that already kind of de-escalates some aspects of patients' worries because they know it's a real symptom. And so if we can go on to the next slide, Rose. So one thing I have learned from my experiences, and I know Rose will probably say the same, is that fatigue doesn't just have one type of fatigue. There are a combination of dimensions, and often patients may have one that's leading more than the other, but they often experience a combination of all three. And that's physical fatigue probably is the one that mostly sometimes is reported first, with the heavy legs, the achy muscle feeling sensation. Patients might describe, it feels like walking through sand, or some of my patients will say in the winter time through snow, where they've had elements of that. But also we've got to remember the cognitive side of it. So patients will describe the mental fog experience, and they might be feeling more tired than usual even after activities where they've had to concentrate, but even just small activities. So they will report things like they struggle to concentrate, losing track of conversations, reading becomes more difficult, and even like making just simple decisions that they wouldn't have thought of before becomes really overwhelming. And then there's the emotional side of the fatigue, as in there's uncertainty of treatment, the bowel dysfunction elements, adapting to possibly a stoma, that fear of recurrence. They're all constant drawing on your energy consumptions. And so one of the common sort of patterns, if we go to the next slide, Rose, that we see is that.
Nick,
Oh,
sorry,
yeah.
sorry to stop you. I don't know if it's just, if maybe your mic needs to just be moved up, or if you need to just move a bit away from it. Just that every now and then it goes sort of tinny.
Can you hear me now? Is that better?
It's much
Or is it
better, thank you.
apologies for that. Oh, okay. So I can hear it actually now. I don't know. Is that better now?
Yeah, I think so. I think.
Okay. Let me know and I'll take it out if it's still doing that.
Okay.
So common pattern is that sort of beam and bust pattern. So you might be aware of this. And what I would say is that sometimes patients will say, yesterday I felt quite good, so I cleaned the whole house, and today I can't get out of bed. And that's that classic beam and bust pattern that you'll see in patients. And what is really happening is people wake up feeling slightly a bit better one day, so that's their good day, and then they naturally want to catch up on everything that they've missed. So they do everything in one go, the shopping, the cleaning, all the jobs that were on the list that they haven't done. And then they come with that real big crash. So that's the trough in that curve on that slide. And that then leads into that bad day. And sometimes that can be immediate effects, it might even be 24, 48 hours later. But what they tend to do is then they spend 2 days or more recovering, and that then reduces their activity levels overall. So eventually what you start to see is actually people are doing less than less before they start to have that good and bad days again. So overall we get into what we call that cycle of inactivity and a reduction in activity overall, which is sort of shown and depicted in the next slide. If those hits the next slide.
Sorry, Nick, before you get to your next slide, I think you might need to take it out. It just keeps going sort of like there's a tin noise. How's that? Is that?
Is that better? I've just taken it out. Can you hear me?
Oh, that's fabulous. Thank you.
Okay. I'm so sorry that was happening.
No,
But what
it's
you
all right.
can see in the cycle in front of you is that's the cycle of inactivity. So when someone understandably becomes sort of feels fatigued, they will do less activity, and that activity then they will reduce. The body itself becomes it's adapting to that reduced activity. So actually our cardiovascular fitness, our muscles become less efficient, everyday tasks suddenly become a bit heavier to do, and actually simple tasks like going upstairs, which may take 20% of our physical capacity, now is taking 40 and 50% of our activity. So the task itself, it hasn't changed, but the body's ability to perform it has changed, and so it feels much harder. And what you can see is that cycle of inactivity, it continues, and it ends up being a deconditioning cycle, and that's what we need to halt. And so Rose is going to start by kicking off with some strategies that we use to try and break that cycle, and then I'll join you back a bit later.
So Nick's already touched on how sort of a diagnosis, the treatment and everything that comes with it can really have a significant impact on our emotions. And we can't sort of underestimate the impact that sort of stress, anxiety, low mood have on how fatigued a person might feel. And you've probably heard about the fight, flight, freeze response, or the lesser well-known fawn response. When the body senses a threat, the amygdala, that's a sort of area really deep in the brain that's concerned with our survival, becomes alert, and it sends messages to places like the adrenal glands to produce adrenaline and other chemicals. And, this response prepares the body for action, protection, and survival. Once that perceived threat has passed, ideally, we then return to that much more relaxed state. However, if that sort of perceived threat remains, and that can be things like money worries, health concerns, struggling at work, family pressures, that demand on the body is prolonged, and our bodies aren't well adapted to managing that ongoing threat. And that prolonged state really impacts somebody's sort of energy resource and also mental resilience to manage day to day, because your body is using energy to prepare for danger. And it's that kind of perpetual cycle. It's a cycle where stress impacts how fatigued you are, but then the more fatigued you are and how it's impacting your life, then impacts the stress, and it sort of goes round. So patients will explain some kind of different behaviours or kind of signs that might make you think, oh, maybe fatigue is a bit of a problem and we need to offer a little bit of help, and it's worth keeping an ear out. So things like overdoing it, that's the boom bust that Nick just spoke about, that up and down and crash point, but also doing too little, that's your inactivity. Also pushing through is the other one. So regardless of how they're feeling, they push through to finish something, but that will create that kind of crash point. Struggling to ask for help, they can have really great support networks, but it's about how you actually ask for help. Not planning ahead, so they know they're fatigued, but they haven't changed anything, and towards the end of every week they're having to cut things out and feeling really disappointed about that. So not actually planning for the fatigue, and cutting out everything that's enjoyable. The first thing we tend to see that goes off somebody's list in a week are the things that they enjoy, and actually doing things that we enjoy feeds good energy. So it's so important we try and keep some of those up. So moving on to what we actually do about it. So first of all, we do a really detailed assessment to kind of establish what sort of interventions and strategies might be useful. And unless we know exactly how it's affecting the person, we don't know which ones to choose, because there's lots of different things we can do. It will include kind of looking into somebody's diagnosis, treatment, comorbidities. We'll always start with linking in with the medical and nursing teams to work out if there's anything that we can optimize, because ideally we want somebody working from the best baseline possible. So any way we can improve something, first of all, that's where we'll start. We'll look at how the fatigue presents, so what it's like day to day, the patterns, the triggers that will be really individual person to person, any other symptoms, so sort of sleep, pain, any other medical conditions. We'll think about what their home is like, what their physical functions like, any neurological, cognitive symptoms, their work demands, long-standing behaviours and lifestyle factors. So actually understanding, somebody's value, what drives them, how they normally manage and respond to sort of situations will allow us to adapt our communication and how we're going to work with somebody. Understanding their support networks, thinking about nutrition and also mood that we've sort of touched on. And just honing in a little bit on sort of what motivation and behavior change is, because making a change, it's really hard. It's really hard to start something new for everyone. It's a lot harder when you feel overwhelmed, sad, anxious, and just juggling all the kind of logistics that a diagnosis can bring. And we can all think about this. If you think about a day that you feel really, really exhausted, you've turned up to work and suddenly you're asked to do something different that you don't want to do, and how prickly you might feel about that compared to a day when you feel absolutely fine, or a day when you feel really overwhelmed, sad, or anxious, and somebody asks you to be extra flexible or do something out of the norm, and how much more difficult that is. So it's really hard actually to start. It's really hard to sustain, but it's much harder when your symptoms sort of make your flexible thinking more difficult and the physical effort more effortful. And that's where our job really as clinicians is to help people feel able and open to kind of engage in trying something out, doing something new, even when it's really, really hard. We do this by really bringing patients into sort of their own goal setting, acknowledging whatever their big goal is. So even if we think that's quite unrealistic, hope is always it's so important. And what we then do is focus on what the first small step is with somebody. And I think why I sort of say always acknowledge the big goal, because actually what we tend to find that either patients surprise us and what we thought was unrealistic is actually achievable, or that goal just adapts and changes over time as they become more confident in managing it. So we sort of don't challenge that too much, and we just start with whatever the small step is. And thinking about motivation, what helps? So first of all, being interested, actually being something that matters to you. And that's where the self-led bit comes in. Knowing that the hardest part of doing anything is actually the first step. So we often plan out what we're going to do at the gym rather than the goal around how we're going to get to the gym. But the chances are that once you're in the gym, you will do something. So if your goal is around how you're going to get the bus there and who you're going to meet to make sure you go, your chances of actually doing something will be higher. Lots of rewards, rewarding early, lots of small steps, thinking about cues and anchors and prompts. So how can you pair it with something nice, or who can you link in with that makes it that kind of familiar task that you're going to do? Consistency and repetition really help, because then it's easy for your brain. It's that neuroplasticity and thinking about any kind of emotional support you might need. And that could be formal or informal. And just before we go on to the strategies, we'll just mention a kind of the common concept we use to help explain to sort of patients how their body might be managing fatigue if there's somebody who's sort of managing energy if they're struggling with fatigue. And you can think about this as a kind of battery that you start with a certain amount of charge in the morning. Now that will vary from person to person how you might wake up feeling. If you only do things that deplete that energy reserve or your battery, so things like housework, lots of conflict, going to a stressful job, your sort of battery is going to drain quite quickly. Vice versa, if you do things that charge up, so you use a bit of energy, but then you do something that puts energy back in, you're going to help balance sort of and charge up your battery. You can also think about a bank account where you spend a bit and you put a bit back in, spend a bit. I think that's quite a good motto for life. So for the balance, our bodies need to move between a range of different systems to enable us to do what we need to be able to do, but also to regulate the systems in our body. One of these systems is what we can describe as the drive system. So that allows us to get things done. It's very active, it helps us make decisions, it can feel really good and productive, it can be exciting, and it's quite dopamine driven. And although drive can feel really good, it can also be quite energy depleting, particularly if you're somebody experiencing fatigue. So to have energy to drive, you need to be able to have time to recover from that more activated state. And that's your rest and digest type of symptom, or we can call it your kind of soothing system. And that's allowing yourself time and space to kind of engage in activities that are more soothing to help your body top up that energy reserve and do lots of the kind of vital processes that are needed to be able to move back into your drive system again. And I'll hand back over to Nick.
Hello. I've put on the mic just because my environment's a bit busy, but if it's doing anything that you shouldn't do, just let me know again. Is that okay? So exercise is one of the strategies that we do use in our clinics. It's probably the intervention that I would say surprises people the most. We find that many people naturally sort of reduce their activity levels when they are diagnosed with cancer, and the natural instinct is to rest when they feel fatigued. So when we then say actually exercise is a treatment of it, there is some conversation, and obviously we have to, present, why exercise really is of benefit to our patients in terms of treating fatigue. What I would say is, from an evidence base, it is the recommended and the one that has the highest level of evidence to support in treating fatigue, but it has to be delivered in the right way, and that will be evident later on when we look at the guidelines and what actually the recommendations are. And the biggest thing about the exercise component is that, creating activity in people's plans, is because, remember, one of the biggest drivers is that deconditioning and inactivity cycle, and that's exactly what activities start to break. Okay, so I would say when it comes to someone going through bowel cancer treatment, exercise doesn't necessarily mean joining a gym. So that's the important thing. It can be joining a gym, and that might be important to someone, but it also doesn't have to be that. It can be things like 10 to 15-minute bouts of walking before and after, particularly like a meal, say breakfast or lunch, that you're incorporating into someone's day, so that you're really getting a routine present more than anything. It can be doing certain exercises at home, like resistance exercising, using bottles or bands that can be given to patients. And for someone who's got, for example, a stoma, it might be rebuilding their confidence and their core muscle strength around moving again. So they will have some really targeted and specific programs that they may need to have, and particularly if someone's got if there are bladder and bowel urgencies as one of their symptoms, it might be that it's incorporating things like knowing that they've got a toilet that's nearby to wherever they're going, if we're encouraging certain activities. We run at our centre sort of a 10 to 12 week rehabilitation programme, post those going through treatment, and that goes on to help integrate them into community settings as well. But within the sort of exercise guidelines itself, you'll see in front of you, we've got what the national recommendations are, and that is people should be doing 150 minutes of moderate amounts of aerobic activity minimally each week, and that is a minimal standard, which is 30 minutes of aerobic exercises 5 times a week. So we have to ask ourselves, are we doing that before what we're going to then engage in a conversation? What's the likelihood our patients were doing that before they've had their treatment? On top of that aerobic activity, the guidelines are that that all of our patients should be doing strength training 2 times a week, and also if you're over the age of 60, you should be doing flexibility training. So you can see, like, those guidelines haven't actually changed from the us as anyone not going through treatment versus those who are going through treatment. The evidence base shows us that they should be able to still adhere to those guidelines. But what we know is that if someone's got fatigue, they're not going to start there. That is not where they're going to be as their starting plan. And actually, the art for us is really supporting someone in balancing, okay, how do we slowly get to integrate and increase in activity levels, and then also balancing areas of replenish activities where they're replenishing their fatigue levels. And so I'd always say you start off with low level exercises, increasing someone's time, and then you build in intensity later. And that's what the recommendations are in the guidelines for someone with fatigue. And if Rose quickly pops to the next slide. What you've got is some resources that we've created that are on, so the QR code will take you to the website, but we've got some physical activity and exercise resources that are tumour specific. So there's one for colorectal and anyone going through bowel treatments, whether it's chemotherapy, surgery or radiotherapy. And there's specific advice that all healthcare professionals can access to give advice to their patients around how they can become more active during and after their treatment. And then we also have some other resources which guides patients through which is our physical activity module, which is the next slide, Rose. And that really, again, that that has advice for patients going through all the different treatment modalities prior to the treatment and after treatment, but it also gives patients videos that they can follow along that are different levels. So we have low, medium and high levels in that module that patients can access, and it also has activity plans that patients can download, particularly also if they're going through bowel treatment regimes, and also referral options. So there's some key resources that can access around it. But what I would also say that's one of the things, particularly when we're trying to get the right activity balances, is that we need to plan and prioritize with our patients. So that's where you can now see in front of you the next slide, and that is what's one of the things that can be misunderstood aspect around fatigue management is how we really pace the activities into someone's sort of daily plan. And what we tend to use is the sort of like the 5Ds to help us coach our patients to be able to do this. And that is, firstly, think about the activities that they do need to do. So what generally needs to be done today, and it's important that they need to do, and that should be, yes, it could be the household essential jobs, but it also has to be something that they enjoy as well. And then what tasks and jobs in that day can they downgrade, so that can be made easier? So that is, can they sit instead of stand to do a certain task so they can conserve some energy? Can they do an online shop rather than go out to the supermarket, which means they conserve energy, and then they can move on to do a task that they prioritize as more important for them? Is there an element that they can delay in doing a task? Does it really need to be done that day? Can they delegate, which is really a hard thing because no one really likes to delegate tasks to someone else, but can they delegate that task to someone else? Does it really need to be them that does it? And actually, are there tasks that actually you can ditch? You can totally remove, and that does require some long-standing behaviour change, but it is elements of the coaching that we will do in some of the strategies that when patients see us. And then I'm just going to pass back to Rose.
So something else we will look at is obviously sleep, because I think we all can relate to and know that sleep is incredibly important. It helps the body and the mind, it helps our body repair, and it helps with hormone balance, strengthens our immune system, it gives us a sense of kind of well-being and emotional balance, it helps with our cognitive function and just generally feeling really motivated. And 1 or 2 bad nights of sleep is common for anyone, but for somebody with fatigue, it might be a lot more regular or frequent. And it can be a little bit chicken and egg, because sort of feeling fatigued can actually impact the quality of your sleep, but also sleeping badly can sort of make your fatigue worse. So it's something we have to work through sort of in combination with our fatigue management. And when people explain sleep problems, it's important to understand what aspects of sleep are difficult, because again, that will depend on the kind of strategies that we use. So things people might sort of pick up is that they're sleeping for a long time, and then they might also not be waking up feeling refreshed. So that goes back to what fatigue is. It's often that not feeling refreshed despite the amount of rest you're maybe getting, often struggling to then get up in the morning, not feeling sleepy at a normal time that we kind of call sleep pressure, but often feeling exhausted in the day. So you might feel a bit wired, but also very tired. Waking up in the early hours and then not able to get back to sleep, that kind of 3 a.m. club that I think we've all at times been a part of. And there's also the physical causes, and that can be things like changing to kind of bowel habits, urgency, needing to get up to the toilet more often, abdominal pain, bloating, discomfort, hot flushes, anemia caused by sort of that can impact tiredness as well. And I can't go into sleep in detail. It's sort of, we could do a whole other presentation on it. So I've tried to pick out some of the kind of key bits that we'll give to everybody to help try and optimize their sleep. And again, we look first at, is there anything medically that can be optimized? So that might be checking bloods. It might be thinking about other, reasons around the increased need for the toilet that can be adapted and changed. Looking at nutrition, any changes to kind of nighttime sweating and cramps and things like that. So if there is anything medically we can optimize, we need to go back to the MDT and be asking about that. But some general information that can be helpful. So eating and drinking well and enough water, but that needs to be individual to the person, because different people will have different kind of plans. So when I say that, it's just with the caveat of whatever is right for the person. Thinking about kind of regular times to go to bed and get up. Now, you can't often we can't be regimented about this. It might be changed day to day around appointments and things like that. But where we can, our bodies love that repetition. So if you can make your body aware when you're roughly going to go to bed and when you're going to get up, that can be really helpful. Having wind down routines is really helpful. So rather than getting into bed, trying to go to sleep and instantly feeling frustrated, actually giving your body time to cue in to that you're going to get ready to sleep. You can think about sort of relaxing music, gentle stretching, reading, meditation. And again, it's cueing your brain into, yeah, right, it's getting ready for sleep now. It's not on this slide, but a really important thing is morning sunlight, and it really helps with that kind of sleep-wake rhythm. So getting out into natural light is really helpful. Making your bedroom a calming place, so removing devices, removing blue light as far as possible, thinking about softer lighting, the right temperature, comfortable bedding, things like having 2 single duvets instead of a double duvet so you can regulate the temperature that you want, having extra fans. If thoughts and feelings are what are causing you to sort of stay awake in the middle of the night or struggling to get to sleep in the first place, working out what anxiety management strategies are helpful for you, but practice these in the day. So it's going to be no use trying anxiety management strategy for the first time at 3 a.m. in the morning when you're feeling really stressed and really anxious about how it's going to impact the next day. Get your brain prepped, get it, something that works for you and you can use quickly, and you have that prepared to use. And if nighttime waking is unavoidable, think about ways to reduce sort of the impact of this. So before you go to bed, it might be having additional bedding that you can pull onto your bed quickly overnight, or a change of clothes. Do you need to sleep closer to the toilet? Change where you're sleeping. Commodes, urine bottles can be helpful. During the wake up, keeping lights low, using night lights can be helpful. Having some sleep headphones ready with a guided relaxation ready to go if that's something that's going to be helpful to do. Earplugs and things like that can be helpful as well. And getting referred to the right services. So whether that's around the reason for the nighttime wake ups or getting help specifically with the sleep. Moving on to naps, I think get a lot of bad press, if I'm honest, because I think naps can be incredibly helpful, but there are quite a few caveats probably around that. So ideally keeping them sort of short and early enough in the day so that they don't affect your sleep, ideally at night. If you don't wake up from a nap feeling energized within a reasonable amount of time, and you have that kind of groggy sedative feeling, or that you notice it's preventing you either getting to sleep or not sleeping enough, then it might be worth looking at kind of tweaking what's going on and moving what's going on. Ideally set an alarm and have something planned that's really enjoyable. So, having that task that you really were dreading doing to do after your nap is going to make it really hard to wake up from that nap. But if you first plan something that actually you want to get up for, however small, it will help you wake up. And just noting that there might be times through active treatment or around your diagnosis that you need a bit more sleep. So again, it's fitting this around what's needed, what's right for you, and it needs to be individual, and making any sort of changes slowly, rather than suddenly cutting something out that might just cause an extra crash over time. And obviously, if you notice any of these, getting referred. And so that kind of rest and switching off is a key concept to help you put energy back in, to kind of top up your bank account with that kind of soothing system activity. It tends to work best where you're doing sort of things that are sort of small and frequent to top up your energy reserve, rather than big chunks of something that's draining and something that's soothing. With fatigue, it's important to note that actually your body isn't good at sort of pre-warning that a fatigue crash might be coming. And one way we kind of explain this to patients is everybody sort of heard that by the time you feel thirsty, you're often quite dehydrated. And actually fatigue is really similar in that way. So often by the time you feel quite fatigued, you might not be able to do something small to top up your energy levels anymore, and it will cause more of that crash and that longer time in bed. So it's doing something really sort of intentional to make a choice to rest or do something relaxing rather than waiting for your body to tell you. Or the other thing you could do is switching the type of activity. So while one part of your body is working, the other part is relaxing. So you might be doing something quite physically draining, and then you change to do something more cognitively draining, while physically you can rest a bit more. And that works really well in a kind of work setting where you might be able to kind of chunk the types of tasks that you're doing. So for many people, the quality of their rest can actually be very poor. So they might be spending sort of hours of time being inactive, but without knowing it, they're sort of inhibiting their body's ability for quality rest and recovery. And things like this that are typical for that are things like doom scrolling or really passive TV watching, those kind of stimulants, and how they kick into the brain's response and don't actually allow for proper rest and recovery. Everyone's different. So some people feel really uncomfortable stopping activity altogether. And if you're lying there just feeling stressed about what you're not able to do, you're probably not going to be feeling more relaxed afterwards. And the purpose of rest is sort of to feel relaxed. So if that's not working for you, you need to think about different things like guided relaxation or something that's sort of a gentle activity that you find relaxing. So we do tend to change rest from, stopping activity altogether to more thinking about what you find relaxing, what your body needs to move into that soothing system. You do need to be realistic. So think about what type it is and what length you can do within the environment. So what you might be able to do in a workplace setting might be quite different to what you can do at home. Just touch on here some of those kind of different types of rest that we suggest to our patients. Is definitely not an exhausted list, but things like grounding, breathing techniques, body scans, diffusion techniques, and accepting emotion exercises that comes from kind of acceptance commitment therapy, mindful activity, mindful movements, lots of different kinds of sort of green, brown, pink noise, lots of music kind of things. Bidirectional music is something that people quite like at the moment, and also stretching. And we touched on sort of the impact that sort of mood and stress and our emotions can have on fatigue. There's so much we can do to help somebody with managing that, and also their perception of their fatigue as a whole. And this is just a kind of list of some of the things we work through with our patients. So yes, the anxiety management that we've spoken about, mindful self-compassion, that's a really important concept around reducing our stress response to how we're feeling and talking to ourselves. Physical activity is really key to our mood, spending time in nature. What support networks do you have? Doing things you enjoy, reducing stresses where possible, considering your screen time and the massive impact that can have on our mood and our emotions, our quality of sleep, nutrition, and getting, more formal psychological or coaching support if you need. And my last slide is just around kind of vocational rehab, because obviously it can have a massive impact on how somebody is able to stay in work or return to work. We often see people using up all of their energy completely at work and not have any of their work-life balance. So it's really important to remember that employers are required to make reasonable adjustments, and I've sort of outlined what they are in this slide here, but that's covered by the Equality Act. We still most commonly see a kind of graded return or reasonable adjustments that's just building up hours over 4 weeks. But actually, there's just so much more that can be recommended to support somebody. And that can be things like more frequent breaks, working from home, shifting your start and finish times to avoid rush hours, considering your workload. So it's sort of more favoured towards the kind of things that you find the easiest at work, and redistributing things that are more draining for you, and also what environmental changes can be made. And we do a lot around helping to foster good relationships with the manager. So actually that open communication where possible, and bringing proactive strategies that will help you do your job to the best of your ability. So having a really positive approach to how you're going to have those conversations, becoming an expert in your own symptoms. And just if you can refer on early. So the more we can see patients earlier, if you have any local services that can and prep somebody up to practice work-like activities, practice their strategies, means that you're preparing somebody to get back to work rather than doing that in the job when they get back to work, and linking in with any coaching support to help them sort of foster those good relationships. Right, I'll hand over to Nick for the last few slides.
Yeah, so there's only a couple of more slides, but I'll be quick for the interest of time. So if we go into the next one, Rose. So we can. There you go. So I don't know if you guys are aware of it, but there is the National Comprehensive Cancer Network who have developed the cancer-related fatigue guidelines, and that was published this year. You do have to log in and sort of register with them to download the guideline that they've generated, but it's incredibly useful in sort of how to structurally manage fatigue, and though it's developed sort of in our Northern American counterparts, and by them, it is internationally recognised. And so what we've done is we've gone through the guideline, and in front of you is actually all of the kind of steps and the components. So we've put that together for you guys today, so that you can see the different components that is included in the guideline. But it is the principles are the same what we use in the UK, and I think what is particularly something that I like about the guideline, it really treats fatigue simply like all of the other symptoms like pain and breathlessness. So it shows that you do need a structured management sort of system to help manage it. And you can see the steps there that actually, you know, screening is important. We do need validated tools as part of that screening process. Assessing the patients, treating those reversible causes is a key thing. Implementing the personalised management interventions they have laid out, and they lay it out with the evidence base that exists, and that's really important. So you can see the strongest to the least strongest evidence for which interventions are most importantly used for fatigue, but they do recognise that everyone is an individual. So actually, what works for one person might not work for the other. And then there's a key bit around it about reviewing and monitoring, and that's really essential. And that's because fatigue changes, treatment changes, you know, recovery of a patient changes. That pathway is not the same for one that is for the other, and that's really important. And that's why reviewing and monitoring is an essential component of how you manage fatigue. So it's something that we have to incorporate into it as well. And then what we've got is in the last two slides is just some resources that you can access. Our first resource is one that we've developed with a multi-professional team. So that's physios, OTs, it's our specialist nurses. We've had our complementary therapists, dietitians, and our psychology team all input into developing a fatigue module for patients that they can access with all the sort of interventions and some of the strategies we've talked about today, but there's much more on that. So you can all access that too through the link. And then also we've got on another page just some helpful resources that pulls and links some of what we've spoken about today with the physical activity resources that we have, but also some others like Macmillan have some great resources that that you can use with some small sort of bite-sized videos that complement it, which I think Rose helped support with some of those generations too. So I think that's probably where we'd like to finish off, and I know we're out of time, so apologies for going over a little bit.
No, you didn't. That was great. Thank you both so much. That was really, really informative. We've got quite a few questions, so we'll move on to them. But just to say that the managing cancer-related fatigue guidelines and the way you've broken those down looks excellent and really helpful. And just the thing about reasonable adjustments, I don't know about anyone else, but I'm really bad at remembering that I should say that to my patients. You know, from the beginning, you can get reasonable adjustments. Yeah, thank you. Yeah, if we could invite all panelists back on screen, that would be great. We've got quite a few questions that have come in. One for you here, Sue, from Catherine saying, thank you for your presentation. Is there anywhere we can access the gentle FODMAP diet? I think you did say it, and maybe it's in your resources, but just if you could quickly answer that one, that would be great.
You could just Google it actually. If you Google Monash University Gentle FODMAPs, you will find it.
Okay.
It is in my list of references as well, though.
Brilliant. Thank you very much. That's great. I think this is for you, Anna. Do you do breath tests for SIBO, or do you trial antibiotics? What's your approach?
I like doing breath tests for SIBO, but I don't do it in the NHS setting often because it takes such a long time.
Yeah.
Our waiting lists are horrendous. So I suppose my answer would be is if you could access it quickly, I would do it because I do think it's helpful. But I sort of feel that it seems a bit mean to keep patients on waiting for months and months and months. So I do give them a trial of antibiotics. I do give them a trial of rifaximin.
Yeah. Okay. Yeah. We have the same problem. It's difficult. The waiting times are so long that it's really difficult.
Yeah.
Yeah. Okay,
Yeah.
thank you.
I mean, if they don't respond to rifaximin and I still have a slight suspicion, then often we'll refer afterwards just to make sure that it's not sort of methane predominant and that there's no role fighting neomycin and things like that. But I don't know. I I don't
So
really
if clinically the picture fits, you'll just
Yeah,
trial.
absolutely.
Yeah. Okay. Thank you. I think this is a question for you, Isabel. It's about for women that have had radiotherapy and APR or ultra low anterior resection who experience pain during penetrative sex. What advice do you give? Is there specific advice regarding positioning and trying to make that more comfortable for them? Because we do see that quite a lot when you start to speak to ladies.
I think obviously one of the things that we want to do is try to find out the nature of the pain, where the pain is situated, what makes the pain worse, what relieves the pain, because we want to understand the underlying mechanism for the vaginal pain, not just the fact that there is pain. So we want to know whether there's superficial dyspareunia in terms of whether there's pain on the actual vulva and at the introitus, or indeed whether the pain is deeper inside, because that might give us clues as to what the mechanisms causing the pain are. And that feeds into then the type of advice you give. So if, for example, it's mainly introital pain, but the pain's not so much deeper inside, or the pain is at the beginning when penetration is just starting, but once the partner's penis or a sexual toy is actually inside, then the pain dissipates and it's not there, then that might indicate that it's more hyperactive pelvic floor, problems with the introital tightening, which could be either anatomical, caused by the radiotherapy, or could be functional in that it's to do with anxiety and fear, or the experience of pain actually causing people to tighten up the introitus. Because obviously the only part of your vagina you've got any conscious control over is the actual vaginal entrance in terms of your pubococcygeal muscle. So what's happening inside, you've got no ability to make that tighter or more open. So once you kind of suss that out, you'll give advice around being able to perhaps have pelvic floor exercises. You might refer for pelvic floor physiotherapy, depending on whether it's introital pain or not. If it's pain during thrusting, then you obviously want to also review what they're using, if anything, in terms of vaginal products. So, for example, if they're a premenopausal woman, you'd want to know whether or not they're on HRT. If they aren't, they should be. And even if a systemic HRT is contraindicated for reasons other than the cancer, because generally in colorectal cancer, you're not worried so much about it being a estrogen receptor positive tumor as you would be in some gynae cancers and breast cancer. Again, you're wanting to find out whether they're on topical estrogen, if they're not on systemic estrogen, and if there's any contraindications, then usually topical estrogen is safe compared to, say, systemic estrogen. If, for example, they've got a history of pulmonary embolism or stroke, or they're very overweight, for example, and they might be at risk from systemic estrogen, you can usually give them topical estrogen, and that will actually help with a lot of the vaginal atrophy that's caused by treatment-induced menopause and changes associated with radical pelvic radiotherapy. Then when you're looking at positions, you can consider the female superior position. So generally speaking, when women have had sexual pain and you're trying to get them back to being sexual again, if you get them to, again, it has to be obviously acceptable to them, because for some they might feel quite exposed in terms of feeling vulnerable by being seen by their partner, because they're sitting on top of a male partner rather than actually lying underneath a partner. But by going on top, you actually control the depth of penetration, the rate of movement, the angle of penetration much more completely than if you're in the missionary position and you're lying underneath. You're then dependent on the partner coming into you in a way that's actually compatible with the position of how your vagina is lying and how your pelvis sits. So we often get women to practice being on top of their partner, and for them to then think about, leaning forward and changing the angle rather than sitting bolt upright. So again, just being able to trial and error with the actual angle as they're actually moving. And again, being able to get that containment and knowing that it's not painful when the penis is in there and static, then allows the woman to actually control movement in terms of how much she's going to move. But depth of penetration is always minimized by being on top. The other position, if it's related to deep dyspareunia, in other words, when it's deep thrusting, the worst position is like doggy style, because that enables a very deep penetration. So we would tend to use either female superior, or we do side lying. So we would suggest that the woman lies and it's like the couple are spooning. So the man, the male partner would be behind the woman and would be actually going through her legs, sort of through her buttocks and her legs to actually go, because again, that usually means that you've got a much smaller amount of penis actually going into the vagina. And so again, it can control for depth of penetration. And then the use of those O-nuts, which are like a series of silicone rings, they're really, really useful also as a pain buffer. So if you've got pain, but you don't want to do side lying and you want to do missionary more, then the partner wears one or more of those silicone rings. They come in a set of 4, and it just helps reduce the depth of penetration, particularly if the partner is quite well endowed, and the woman may or may not have had some vaginal changes as a result of either surgery or indeed radiotherapy changes. So that would certainly reduce depth of penetration. But a lot of it is trying to work out what the underlying mechanism for the pain is. So do you need to reduce friction as well as change position, as well as actually loosen the tightness around the introitus, maybe because of hyperactive pelvic floor? And then the other thing you can do is you can put a little cushion underneath. So if you're wanting to tip the pelvis slightly, so you put like a little cushion or a little little cushion or pillow, just to tip the pelvis up slightly. Again, that changes the angle of the vagina and can make penetration more comfortable. But a lot of it is trial and error in terms of what's actually going to help.
Okay, thank you so much. That's a really helpful answer. Thank you. Right, I've got some more questions. I think this is probably for you, so you might have experienced this as well, Anna. Have you experienced this shortage of pancreatic enzyme replacement therapies like Creon? And how should we be managing that? And there's another part to that question, which is, do you manage the dosage, and how do you do that?
Do you know, I don't tend to, because I very much specialized in the lower GI tract. So I very much specialized in colorectal. So I would tend to either defer to my dietetic colleagues or to my hepatobiliary colleagues, actually, in terms of Creon. But I do know that there has been a shortage. I'm sure Sue will tell us on and off. And there are other issues on there about what Creon contains and the alternatives, which we want to discuss, which is sometimes quite difficult from particular religious beliefs.
Yeah, Sue, would you like to?
Yeah, so I mean, we've had a lot of problems with shortages, and I know that a lot of our patients have as well, but it does seem to be quite, I mean, I know people, I mean, I don't think the Royal Marsden seems to have even noticed it, and Lincoln, they don't seem to have very much, but there's definitely another round of shortages. And there was a position statement that came out, I think, well, in the first week of June, and I have actually got this on my resources somewhere. So this isn't as bad as the shortages were before. So the message is that everyone who needs to have pancreatic enzyme replacement therapy should be able to get hold of something. It just may not be the one that they're normally using. So at the moment, there's Creon, Nutrizyme, and Pancrex. There's a capsule and powder. The powder's nearly always reserved for tube feeding. And the Creon 10,000 capsules, the smaller capsules, they try to reserve for either people that have got swallowing difficulties, but mainly children with cystic fibrosis. But there should be something for everybody. But what we're doing, and I think they'll probably recommend this in the position statement, is that when we write to a GP to request a prescription, we always put, and during cases of shortages, please also prescribe an imported product or Pangrel. Ours is called Pangrel. I think there's Pangrel and Creon spelled with a K. So they're imported products. They're just the same as the ones that we're using over here. But we always put, can you prescribe this as well? Because they're imported, no pharmacy will use the same prescription. So the GP effectively needs to go to their own ICB, but issues 2 different prescriptions so that the patient has, the option of having their normal one or an imported one, and also put the prescription in as soon as you've got the last lot, and most hospitals will issue a rescue prescription if somebody is really running out.
Yeah, thank you.
That's generally.
And as a dietitian, do you tend to monitor the dose and sort of help the GPs to manage that?
In terms of changing dose for the patient, yeah. So, I mean, we often spend quite a lot of time with patients on this because we will talk, questions that like we ask a lot are, do you eat slowly? Are you a medium-paced eater or are you a fast eater? Because that can help to decide whether somebody really needs to spread it out throughout the meal. I mean, I've got a lady who eats like a bird and she sits with her dinner in front of her at the start of Emmerdale, and at the end of Emmerdale, she's still only halfway through. So she's sort of popping like a crayon every sort of 15, 20 minutes. So she's probably having more crayon than somebody that's eating a bigger meal, but because she's so slow, she's spreading, and most of the evidence is to spread it out throughout the meal rather than having them all at once at the beginning. But we'll work with patients to dose according to what they are eating.
Okay.
Although some people just find it so complicated, they just can only really manage with take 2 with a meal and 1 with a snack. And that's fair enough as well.
Yeah, they're not small, are they?
No.
Tablets, okay. Capsules. Thank you very much. That's really helpful. Another couple of questions here. You talked about the low irritant, high fibre diet in patients with LARS. Do you use them with other patients? Use that with other patients?
I mean, we do use the low irritant high fibre diet quite a lot actually. So it's normally if somebody's been on a low fibre diet, we'll start to introduce some of the soluble fibre, which is the low irritant. So we call insoluble or tough fibre the insoluble fibre, and it's just loosely things like the peel on peel, skins and pips and seeds on fruits and vegetables. So somebody could have a peeled apple, which would be insoluble. It's not exactly like this, but if it's got peel on it, it will be insoluble. It's just that soluble fibre is a lot more gentle, can help regulate your bowel movements. And if somebody's got diarrhea or they're having a lot of wind and bloating, we'll often use the low irritant booklet. With high output stomas, we use that too, where some insoluble fibre can be quite tough as well. Or people who've got adhesions, we might first of all switch them to the soluble fibre.
That's interesting. Thank you. Thank you very much. And then just a couple more questions, and then I think we're out of time probably. Somebody's asked here, I don't know, it might be that Sam from our previous session is the best person to answer this, but what advice, suggested intervention could potential referrals could be put in place for someone over 6 months post pelvic radiotherapy with significant vaginal shortening, and they can only insert a dilator around 1 inch in depth? I don't know if anybody feels able to take that question. Isabel, you might.
I mean, I think if they're only 6 months post radiotherapy and they've got very early stenosis or they've got adhesions, then arguably you would be hoping to reverse that situation by actually helping support them to kind of manage graduated kind of dilation. And it may be, again, depending on whether or not they've been able to use a dilator or whether they've not been able to tolerate it. You might go right back to looking at, can they actually insert a pinky that's lubricated? Can they insert an index finger that's lubricated? And you actually go back to the very beginning. I think I would want, with someone like that, I'd want to find out whether they struggled to use dilation at all. And if they did, then they may actually benefit from either being reviewed by a specialist nurse in gynae-oncology or going to see a psychosexual therapist that can actually then sort of, certainly someone who's got a background in oncology like we have at the Marsden, then we're often working with people who've struggled to establish dilation. And we're normally in the situation where we're actually trying to gradually introduce them to dilation, but we would start off with simpler things rather than the dilator. And I think also the other thing to bear in mind is if they've got NHS dilators, which are those horrible flat-ended plastic things, you may actually find that you can get them to use because anything is better than nothing, is actually getting them to use a silicon dilator that's actually got a pointed end, and again go back to the smallest size and then gradually build up. But if they're only 6 months out from their radiotherapy, the amount of stenosis is usually still reversible. It's only where you've got really well established stenosis and shortening that's actually been there for many months or over a year that you might then have difficulty trying to reverse that. So we would always want to try and find out whether or not there's been problems and actually start them back at the beginning again and just gradually support them and see them regularly to review how they're progressing.
Yeah. Okay. Thank you. That's really helpful. I think I need to refer people to you regularly, which I know I can't on all occasions. Thank you. Right. One final question, and then I think in the interest of time, we'll need to stop. And it's for Nick and Rose, please. And it's about the number of times that you need to see patients who are experiencing fatigue. And we really struggle with this, with the fact that people report fatigue. You think you might help when you find out an underlying GI disorder, and you treat that, and you sort of try and improve their bowel function, and you check all their vitamin levels and thyroid and all those things, and then they're still reporting fatigue. How often would you see patients like that? It's because a lot of this, it strikes me, is time. I don't know if Rose or Nick, if you're still there.
Yeah, no, I'm happy to start. I think Rose had a fire alarm go off, so
Oh,
I don't know if she
okay.
was able to log on. So apologies for that. And I think what it comes down to, it's really difficult because we talk about the multifactorial nature. So, like you say, that you might get some of those. You started to treat some of the things, like you said, the vitamin deficiencies and the deficits, but actually, is it also because of the fatigue set in, that whole physical component, the psychological and the emotional elements that cause fatigue, as is that the elements that now need to be treated? So in terms of I think what the important thing is identifying, okay, that yes, we might have we may have reversed some of the causes, but they've still got fatigue, so they might need other elements of the interventions looked at, that's the signpost for referral. So when they come to us, we don't really have a set amount of sessions. We have some programs where we run group programs that could be 6 weeks long. It might be someone who needs some one-to-one and one-off information. That's a one-off session, or it might be that they need that group program, which is 6 weeks, a fatigue management program that they get targeted and specialized input from an OT and physio on, or it could be it's the physical component, so they go over into our 10 and 12-week program. Now, even that program just sets them up on the platform. You don't get reconditioned in 5 or 6 weeks. Reconditioning takes a long time. It's very quick for someone to decondition, but the reconditioning progress, and particularly putting on muscle mass when you've got nutritional deficits and there's a long process of how they have to recover of that as well, it takes more time. So it might be they come into one of our programs, but we then will see them after, because we know the recovery can be longer. Yeah, that's what I would say.
Right. Thank you so much. That's really helpful. And actually, I'd just add to that they're quite often the patients that I've met that really struggle with fatigue are the patients that also need that psychological support, because it's really, so it really is a multidisciplinary approach. Thank you so much. All that remains really is for me to say thank you to those of you that attended. Thank you so much to our speakers. This has been a really useful, interesting session and panel discussion afterwards. And I think we all agree this is about keeping this conversation going so that we really can meet the needs of people experiencing the effects of treatment for bowel cancer. If there are any questions you have in the future, please do get in touch with us at Bowel Cancer UK. We're more than happy to try and help in any way that we can. We are trying to produce a resource to be used in clinic with patients at the moment, with the guidance of patients on the effects of treatment for cancer. So watch out for that. And just thank you very much for joining us this afternoon. And thank you again to our panel and speakers.